I opened it and it was just a huge screen, and I was looking for the buttons, and there was just very few buttons. It's like opening a new iPad. You have everything that you have on a volatile machine, but on a huge touch screen, which was very responsive. I think definitely this machine will make doing ultrasound easier. Hello, my name is Ali Youssef. I am a consultant of obstetrics and gynecology in the University of Bologna in Italy. And I will be talking to you about the importance and the technique of the use of ultrasound in the labor ward. I think that in the 21st century, it is imperative and necessary to have an ultrasound machine in the labor ward, and we will be exploring together why is that important and how to use the ultrasound machine in the labor ward. Before starting, I would like to share with you these practice guidelines that we have published on the Wide Journal of ISWAG 2 years ago. These are free access guidelines, and I would encourage you for an exhaustive guidelines and an exhaustive document about the use of ultrasound in labor to refer to them. We will be talking about the reasons or why ultrasound can be useful and important in labor ward. Secondly, we will talk about the technical part, so how to use ultrasound in the labor ward. And lastly, we will talk about the scenarios when can ultrasound be useful in a laboring woman. First of all, we'll talk about why. We all know now that clinical examination, which is still now is considered the gold standard in the evaluation of the progression of labor, has a high rate of error, both for the detection of the fetal occiput position, which has been found by some studies to reach up to almost 50%, especially in a case of an abnormal position, like the occiput transverse or occiput posterior, which is as accurate as throwing a coin. The same lack of reproducibility and accuracy has been found to a lesser degree in the assessment of the fetal head engagement. And we can see that up to, in one case in 4, that we can misclassify the engagement of the fetal head, which you can imagine what deleterious consequences can have, like the failure of an instrumental delivery, or vice versa, deciding to do a cesarean section in extremely low fetal head, which has serious consequences. It's also important to know that when we need more to be accurate in the labor ward, like in cases of obstructed labor, when there is a caput covering and obstructing our evaluation of the fetal head, that we are even less accurate, okay? Because we definitely can mistake a fetal head to be too low when we are only feeling the caput, or often we cannot feel the fetal head sutures, so we can have a higher error of fetal occiput position depiction. Having said that, we will go to the second part of the presentation, which is how to do ultrasound in the labor ward. And it depends on what is the objective and our aim. And the two main objectives that we can reach by ultrasound are: the first one is the detection of fetal malpositions and malpresentations, and secondly, the assessment of the fetal head engagement. Using an ultrasound in a labor woman should include both the transabdominal approach, in which we can detect the fetal occiput position and the flexion of the fetal head, and secondly, the transperineal approach, in which we can assess the fetal head engagement and rotation, and it can help us a great deal in the detection of malpositions and malpresentations. We should always start an assessment of a woman in labor by using the transabdominal approach, and we have described a clear technique, which is systematic approach to the assessment of the fetal head position, and it should start below the maternal umbilicus in the axial view. We move the ultrasound probe in the transverse view to the suprapubic region, and then lastly we rotate in a clockwise direction the probe to detect the sagittal view. On the first view, the subumbilical transverse view, we should assess the fetal spine. On the suprapubic approach, we should detect the fetal occiput position, and then in the sagittal view we can see how the fetal head is flexed or deflexed on the fetal chest. And this is what we would see in a case of occiput anterior. The fetal spine is anterior in this case. In the transverse view, we go down by the probe, and then we are now in the suprapubic maternal region, and we do not see the fetal eyes, we see the fetal occiput, which means that the occiput is anterior. We rotate by 90 degrees and we detect the junction between the fetal occiput and the fetal spine. So this is an occiput anterior position with a flexed head. Okay, this is the fetal occiput on the sagittal view and the cervical spine. By following the same approach in a case of occiput posterior, what we would see usually on the umbilical view, we will see the spine posterior. We go down, and this is the hallmark of an occiput posterior position in the suprapubic transverse view, is seeing the fetal orbits. So if we see the fetal orbits, this means that the fetus is looking up toward the transducer, and this is a certain diagnosis of a fetal occiput posterior position. By following the same approach and the last step, rotating the transducer by 90 degrees in the obtaining the sagittal view, normally in an occiput posterior position, we should see the fetal chin just adjacent to the fetal chest, so we do not see a space under the fetal chin in a well-deflexed occiput posterior. Definitely using the intracerebral structures of the fetal head, it can help us in detecting the position of the fetal head. This can be done by observing the midline, the thalami, which is an umbrella shape pointing to the occiput, and by seeing the cerebellum, which lies in the posterior part of the fetal head, and it depicts the occiput. So this was the transabdominal approach, the umbilical transverse, the suprapubic transverse, and then lastly the sagittal view. Once we have detected the fetal occiput position, we should go to the transperineal approach. And there we have to get two main views which are particularly useful: the mid-sagittal view, and by rotating in an counterclockwise the transducer, we get the axial transverse view. How to prepare the probe? We should use a regular volumetric or a normal convex two-dimensional probe. We put a lot of gel on the transducer, then we cover the transducer by a sterile glove, and lastly we put a lot of gel on the glove and on the transducer, and then we have the transducer ready to use. Before starting the first times, in order to be able to place correctly the transducer, we start always in the mid-sagittal view, so the transducer held vertically. The upper part of the probe should correspond to the left side of the screen. We can test it by placing the finger on the upper part of the transducer, and we should see a shadow on the left-hand side of the screen. Once we have done this step, we should start in the mid-sagittal view by placing the transducer between the maternal labia, and these are the structures that we should see, and there are mainly two structures that are the landmarks of a mid-sagittal view of an intrapartum transperineal ultrasound. The first one is the maternal pubic symphysis, and the second one is the fetal skull. By seeing this image, the most important and most commonly used and the most studied parameter is an angle. It is called the angle of progression, and it is an angle lying between two lines. The first one, which runs through the long axis of the pubic symphysis, almost dividing it into equal halves, and the second line departs and starts from the lower most edge of the pubic symphysis and runs tangential to the lower most engaged part of the fetal skull. The larger the angle of progression, the nearer the fetal head will be to the transducer, so this means the more engaged the fetal head. So the wider the angle of progression, the more favorable and the more engaged the fetal head is. After measuring the angle of progression, we should go to the transverse view, and we should obtain it by rotating the probe 90 degrees in a counterclockwise view. And you can observe that on this view, we can see the transducer, the fetal skull, and if we have an optimum view, we can see the midline of the fetal brain. There are two main parameters that can be useful on this view. The first one is the simple distance between the transducer and the fetal skull, and it's called the fetal head per name distance. The smaller the fetal head per name distance, this means that head is nearer to the transducer, so this means that head is more engaged. The other parameter that we can measure in the axial view is the only measurement of which is an index of the fetal head rotation, which is the angle between the midline of the fetal brain, okay, and the anteroposterior axis, so a line running through the midline of the maternal pelvis. The narrower the angle, this means that the head has completed its rotation. So if we have an occiput anterior and this angle is almost zero, this means that the head has completed its engagement and is now already and very low in the maternal pelvis and completed its rotation. Whereas if we have an angle less than 45 degrees, this most probably means that the head has not been engaged appropriately in an occiput anterior position. This is an example of an occiput transverse position in a transperineal approach. So we can see here that the midline is transverse, so the midline angle in this case is almost 90 degrees. What about the fetal head flexion? It is important to assess in the mid-sagittal view how flexed the fetal head is. So we know that the most favorable position is a flexed vertex, so having the fetal head well flexed on the chest, and the more the fetal head is flexed, the larger the diameter that presents of the fetal head to the maternal pelvis, so it increases the risk of having a dystocia. The flexed vertex is the most favorable malposition. The deflex vertex presents larger diameter of the maternal pelvis, so it is a less favorable malposition. The brow position is an undeliverable position, so if we detect it, this means that this baby cannot be delivered unless it is a transient malposition. And lastly, the fetal face is an undeliverable position unless we have the fetal chin anterior, so in min to anterior positions, and if we have a capacious and large maternal pelvis. How can we assess the fetal head flexion? This can be done by assessing the relationship between the cervical spine and the fetal occiput. The larger the angle between the fetal spine and the fetal occiput in an occiput anterior position, this means the more the fetal head is flexed. And in these cases, and there are two cases of an acute angle and a very acute angle between the fetal spine and the fetal occiput, and these are two malpositions of the flexion of the fetal head. In an occiput posterior position, it is difficult to measure this angle, but it's not important to have a measurable figure of the angle. It is more a subjective assessment. In the occiput posterior position, it is about assessing the space under the fetal chin. So normally we should not see any space if the fetal head is deflexed in occiput posterior, okay? Whereas here we have an extremely deflexed fetal head, so we see the fetal thoracic spine, the cervical spine, and here this fetal occiput, and we see huge space and huge deflection of the fetal head on the fetal occiput. And this is an unfavorable sign of a fetal head malpresentation. By transperineal approach, if we see the fetal orbit by the transperineal approach, this is a very unfavorable sign and detects whether a brow or a face presentation. Another important issue of this machine is that it's very easily sanified and cleaned, having an ultrasound machine with a few buttons, with a clean mode, which is easy cleanable, can be disinfected really easily. I think it's a huge advantage of this ultrasound machine. This takes us to the last part of my presentation, is to when ultrasound can be useful in the labor ward. First of all, we have to know that there is no evidence that applying ultrasound in all cases is useful. This is a study published almost 5 years ago that demonstrated that doing an ultrasound to every laboring woman to detect the fetal occiput position is not useful, and it may increase the risk of cesarean section. And this was the basis of a very recent recommendation of the Royal College of Obstetricians and Gynecologists, published a few months ago, that says that there is insufficient evidence to recommend the routine use of abdominal or perineal ultrasound for the assessment of the station, flexion, and descent of the fetal head in the second stage of labor. And I think that there is agreement on this issue. So ultrasound diagnosis of malposition and malpresentation is not per se an indication for intervention, but ultrasound can provide very useful information in the context of obstructed labor. And I think that one of the most important applications of ultrasound in the labor ward is before operative delivery. We know now that the most accurate tool for the detection of the fetal occiput position, especially before instrumental delivery, is ultrasound. So if you need to detect the fetal occiput position and you are not very sure about it, you should use ultrasound. And this is what has been updated in the last Royal College guideline, that ultrasound assessment of the fetal head position prior to assisted vaginal birth is recommended when uncertainty exists following clinical examination. And we all know that it is quite common to have a lack of certainty on the fetal occiput position, especially in cases of obstructed labor. Why is it important? It is important before instrumental delivery for many reasons. The first one, if you are using a vacuum, you should place the cup on the flexion point. So if you do not know where is the fetal occiput, you may misplace the vacuum cup, and this can be counterproductive and lead to failure of extraction. Okay. And in case of forceps, you may misapply in a wrong way the blade of the forceps on the fetal head with an increasing fetal injuries. So this is about the fetal occiput position, the importance of detecting it in a dystocia labor and before instrumental delivery. What about the use of transperineal ultrasound? When would it be useful? The most common and important scenario of the application of ultrasound, transperineal ultrasound in the labor ward is before instrumental delivery. And there are two main studies that has helped us to a great deal in knowing what cutoffs should we be using. This is the first study, a multi-center European study on the use of the fetal head perineal distance and the fetal occiput position before instrumental delivery. So we have measured the distance between the transducer and the fetal head, and we detected the fetal occiput position in more than 200 women before vacuum delivery. And we could detect two main groups of risk of instrumental delivery on the basis of ultrasound. So if we have a head perineal distance less than 35 millimeters and an occiput anterior position, the risk of failed instrumental delivery is extremely low. It's almost 2%. Whereas if you have a non-occiput anterior position, so occiput transverse or posterior, and an HPD more than 35 millimeters, there is almost a risk of 1 in 3 of failing vacuum delivery. So this means that if you are not sure about what decision to take, whether to deliver by instrumental vacuum delivery or cesarean section, you can use this data to help you to improve the risk assessment of the failure of the vacuum. What about the angle of progression before instrumental delivery? We have two important figures to use. Before instrumental delivery, if you have an angle of progression greater or equal to 146 degrees at rest, or if you have an angle of progression more than 154 under maternal pushing, these are very favorable signs which are with a low failure rate of instrumental delivery. It's important to use ultrasound even to before cesarean section, and I think that this is one of the most interesting uses of ultrasound. So in case we decide for a cesarean section and we have a deflexed and deeply engaged fetal head, we know that it is sometimes extremely difficult in these cases where you have an occiput posterior and deflexed fetal head. It's sometimes extremely difficult to extract the fetal head during cesarean section. And here, when we can plan beforehand the maneuver of going to extract the reverse breech extraction. So instead of taking the fetal head, which may be extremely difficult and have a high risk of a lower uterine segment injuries and extension, by doing a cesarean section with a planned breech extraction, we can reduce these risks. I will close my presentation by giving 3 examples of other application of ultrasound in the labor ward, which might, in my point of view, it's we have a long list of applications that are increasing every day on how ultrasound can be useful in the labor ward. So this is a first example, a woman who has a history of transplanted kidney, and in most of these cases, the kidney is transplanted in the iliac fossa, and there are a lot of reported cases of renal damage during cesarean section in case of renal transplantation. And in this case, we planified the incision of on the maternal abdomen on the base of the kidney which was just adjacent to the fetal head in the right iliac fossa. So by applying ultrasound routinely in these cases, we had now many cases and with no injuries whatsoever to the kidney. The second one is a quite relatively common problem, which is the vaginal hematoma. We know that sometimes the management of vaginal hematomas, especially the high ones, can be extremely challenging because in these cases hematomas can extend into the retroperitoneum and can be sometimes life-threatening. The problem is that it's very difficult to assess whether we managed it well or not, if we sutured well the hematoma or not, and ultrasound in this case can be extremely important. In this case, we have just sutured a hematoma and we applied ultrasound on the area where the hematoma was. And we can see that in this case, there is still an arterial pulsating vessel feeding the hematoma and extending in a higher vagina. And in this case, we applied the technique of embolization of the feeding vessel, and it was magical for us. And the woman went at home after less than 48 hours, like all the other women that deliver in our labor ward. The last application is, for example, in the management of inarrestable postpartum hemorrhage. We know that the application of the Bakri balloon for the tamponade of the uterine cavity can be life-saving and uterus saving in many women. And it is recommended to use ultrasound always when placing the Bakri balloon for two reasons. First of all, to make sure that we are high enough in the uterine cavity, although almost always the Bakri balloon goes down, and this is normal in the lower uterine segment. That's really important, having an individualized machine. So if you're an expert user with a complex and advanced request, you have everything there. And if you are a simple user, you can have your simple version. To sum up, I think that it's fair to say that ultrasound offers an objective and reproducible method for labor progression assessment, that it can be helpful in certain clinical situations as a complementary tool to clinical examination. So it is not meant to replace the clinical examination, but it is definitely a useful complementary tool. And that we should use a systematic approach both by the transabdominal and the transperineal scan, which can allow a precise diagnosis of malpositions and cephalic malpresentations. So lastly, I would like to thank you for following this presentation, and I hope that you will find it useful in your clinical practice, and stay safe.